Welcome to the Deep Dive. We're here to, well, unlock the blueprints of the human body, distilling that high-level anatomical and surgical insight you need.
Exactly. And today, we are tackling the spinal cord, the real central command, you could say.
Absolutely. It's incredibly high-stakes territory, isn't it?
Yeah.
I mean, the critical link where even tiny errors, they can have massive neurological consequences.
That's right. It demands true mastery. So for you listening, especially if you're aiming for that elite professional level, our mission today is pretty clear. We're going to unpack the whole architecture, embryology, internal wiring, that precarious blood supply, and the key surgical moves when things go wrong, really aiming for that top-tier precision.
And we should probably start with that fundamental, almost paradoxical point, right? The thing that really defines spinal surgery. The cord is shorter than the spine.
That's the absolute starting point for understanding position. The spinal cord itself, the medulla spinalis, it only occupies the upper two-thirds, roughly, of the vertebral canal.
And that canal, just to remind everyone, it's like a protective box.
Exactly. A sturdy, sort of three-sided box. You've got the vertebral bodies up front, anteriorly, then the pedicles and facets laterally on the sides, and the laminae closing it off posteriorly at the back.
Okay, let's pin down the absolute top and bottom limits, boundaries.
Cranially, so up top, the transition is smooth. It just continues directly from the inferior border of the medulla oblongata, right there at the upper edge of the C1 vertebra.
Seamless.
Seamless. And caudally, at the bottom, it tapers down into the conus medullaris. Now, the textbook usually says middle third of L1 in adults.
Yeah, that's the standard line.
But, and this is crucial for anyone doing surgery, the reality is it's highly variable. You absolutely have to be prepared for it to end anywhere from the middle of T11, quite high up.
T11, wow.
Yeah, all the way down to the middle third of L3. That variability, well, it just hammers home the need for meticulous pre-op imaging. You can't guess.
So that L1 rule of thumb is really just an average, a starting point, not a guarantee.
Not at all.
And this length mismatch, because the bony spine outgrows the neural tissue, that forces those lower nerve roots to stretch downwards, doesn't it? Creating the cauda equina.
Precisely. The cauda equina, literally horse's tail. It perfectly describes that sheaf of descending lumbar, sacral, and coccygeal nerve roots. So they have to travel down past the end of the cord, past the conus, before they can exit at their designated bony level.
Much lower down.
Much lower down. And they all gather around this thin strand, the phylum terminal. It's basically a filament of pia mater and connective tissue dropping down from the very tip of the conus, and it acts as an anchor point within the dural sac.
Okay, so given that conus variability we just talked about, how do surgeons get their initial bearings before they even bring in the imaging? Are there reliable surface landmarks?
No, absolutely critical. In the OR, these palpable points are your first line of orientation. Think of it as setting up your coordinate system before you even look at the fluoro. Right. So if you're planning an anterior cervical approach, knowing these is key. The angle of the mandible, that bony point on your jaw, that reliably projects to the C1, C2 level.
Okay.
Drop down a bit, feel for the hyoid bone in the neck, that's usually C3, C4. The big prominence of the thyroid cartilage, the Adam's apple, C4, C5.
Right, keeps going down.
Yep. Then the little dip of the cricothyroid membrane is C5, C6. And the sturdy ring of the cricoid cartilage itself, that lines up generally with C6, C7.
So it's like a ladder you can feel. Mandible, hyoid, thyroid, cricoid guides you right down the mid-cervical spine from the front. What about posterior approaches? Especially in the much longer thoracolumbar spine.
Posteriorly, yeah, we rely more on bone structure that we can feel through the back, the spine of the scapula, the shoulder blade ridge. That's a good marker for T2, T3.
Okay.
The inferior pole, the bottom tip of scapula, assuming the patient's arms are down by their sides, that usually sits around the T6 level.
T6, right.
And then, critically important for any lumbar work, the intercristal line. You feel for the highest points of the iliac crests, the hip bones, draw a line between them.
Yeah.
That line reliably crosses the L4, L5 interspace, or sometimes the L4 body itself.
Yeah.
Absolutely vital for targeting anything in the lower lumbar spine or the cauda equina region.
That makes sense. Provides a solid anchor point down low. Okay, so we have its position, its boundaries, its landmarks. Let's rewind. How does this incredible structure actually get built?
Yeah.
We need to dive into the embryology, the neurulation stages, the blueprints, really.
Right. And understanding this formation process is key, not just academically, but because errors here lead directly to those spinal dysraphism disorders we see clinically. It's complex, way more than just zipping up a tube. We usually break it down into three main phases.
Okay. Walk us through the timeline, starting with primary neurulation.
So primary myelotomy happens really early. We're talking 25 to 32 days after fertilization. That's stage 9 to stage 12 embryologically. It starts with the neural plate, which is this flat sheet of specialized cells. It forms a groove down the middle. Cells right at the midline hinge point, they change shape, become wedge-like. This allows the sides, the lateral edges, to lift up, fold inwards, and eventually meet and fuse along the top, the dorsal aspect.
Like folding a piece of paper.
Sort of, yeah. But the fusion isn't instant along the whole length. It starts near the future hindbrain, around somites 1 and 2, and then it proceeds in both directions up towards the head, and crucially for the cord, down towards the tail, the caudal end. It stops around somite 31, which corresponds to the future S2 level.
Okay, so primary neurulation builds the brain and most of the spinal cord, down to about S2. But the very bottom tip, the conus and the phylum, how are they formed? That's different, right?
It's a completely different mechanism. That's secondary neurulation. Happens a bit later, around days 39 to 41, stages 12 to 17. There's no neural plate involved here. Instead, you have this cluster of pluripotential cells at the very caudal tip called the caudal eminence.
Call eminence.
These cells undergo a critical change, a mesenchymal to epithelial transition. They basically organize themselves into a solid rod, a cellular cylinder. Then, this solid cylinder hollows out internally a process called cavitation. And this newly formed tube then fuses pretty seamlessly with the end of the neural tube formed by primary neurulation.
Seamlessly, usually. But isn't the meeting point where these two totally different construction methods join up, isn't that a higher risk area?
Absolutely. That's what we call junctional neurulation. It's this dynamic zone where the primary plate-derived tube meets the secondary cylinder-derived tube. Because integrating these two processes is inherently complex, this junctional region is unfortunately a frequent site for some of the most severe neural tube defects.
Right. It makes sense that the handover is tricky. So, okay, we've got the basic tube built. But how does it get organized internally? How does it know where to put, say, motor neurons versus sensory neurons? What dictates that functional layout?
That internal organization is governed by differential gene expression along 3 main axes. Think of it like spatial coordinates. First, there's the rostrocaudal axis head to tail. This determines the segmental identity, like C5 versus T10. It's largely controlled by a family of genes called homeotic or Hox genes.
Hox genes, right?
But here's a fascinating point. The spinal cord doesn't seem to decide its own segments intrinsically. The final pattern, where the 31 pairs of nerves will exit, is actually dictated by signals coming from the adjacent tissues, the somites, which form the vertebrae and muscles.
So the body segments tell the nerve cord how to segment itself.
Exactly. The surrounding structures impose the segmentation pattern onto the neural tube. It's dependent on external cues.
Wow. Okay, so that's head to tail. What about the front to back, or motor versus sensory organization?
That's the ventrodorsal axis belly to back. And the key player here is the notochord, a rod of tissue lying just ventral or underneath the developing neural tube. The notochord releases signaling molecules like sonic hedgehog that induce the ventral half of the neural tube to become the basal plate. And the basal plate is destined to generate primarily motor neurons.
Okay, so ventral is motor, driven by the notochord.
Right. And conversely, the dorsal half, further away from the notochord signals and influenced by signals from the overlying ectoderm, develops into the alar plate. This becomes the primary site for sensory neuron development. And separating these two functional zones, basal and alar, is a faint groove called the sulcus limitans.
Basal plate motor, alar plate sensory, separated by the sulcus limitans.
Got it.
And the third axis, outwards from the center.
That's the radial axis, defining the layers within the tube wall. Innermost, lining the central canal, is the ventricular zone. This is where the neuronal precursor cells divide.
The nursery, basically.
Exactly. Then the newly born cells, the progeny, migrate outwards ventriculofugally, away from the ventricle. They travel along guide wires made of specialized radial glial cells. They settle in the next layer out, the intermediate zone or mantle zone. This layer becomes the gray matter, packed with the cell bodies of neuroblasts and glioblasts. Okay.
And the outermost layer is the marginal zone. Initially, it just contains the migrating cells processes, the axons and dendrites. This layer will eventually become the white matter tracts.
Ventricular intermediate marginal zones. Okay. That detailed construction process brings us right back to where we started with the ascent of the cord. Why does that happen if everything starts out aligned?
It's all about differential growth rates. In the first trimester, the spinal cord pretty much fills the entire vertebral canal, extending right down to the coccyx. But starting in the second trimester, The bony vertebral column begins to grow much, much faster than the neural tissue within it.
The house grows faster than the occupant.
Perfect example. So the cord's relative position ascends. By about week 25 of gestation, the conticus, the tip of the cord, is already up around the L3 vertebra. By birth, full term, it's typically found somewhere between L1 and L3. And finally, in adulthood, it settles at its final position, usually around the inferior border of the L1 vertebra.
And the nerve roots originating lower down just have to stretch further and further to reach their exit foramina. Exactly. That elongation creates the cauda equina. Meanwhile, the filin terminal, that anchoring strand, it remains attached way down near S2, reflecting the cord's original extent.
This developmental mismatch is the direct cause. But as you mentioned, sometimes the underlying closure process, especially caudally, goes wrong. That leads to the spectrum of spinal dysraphism. Can we define those clinical conditions? Start with the mildest.
Sure. The mildest form is spina bifida occulta, often found incidentally on an X-ray. It's basically just a failure of the bony arch, the spinous process or lamina, to fuse in the midline. Usually there's no neural tissue involved, no cyst, and often no neurological symptoms. Maybe a hairy patch or dimple on the skin overlying it.
Okay, then we get the forms with cysts, the meningocelli.
Right. A meningocelli is where the meninges, the coverings of the cord, herniate out through that bony defect, forming a fluid-filled sac visible on the back. But then this is the key distinction. The neural tissue within that sac is structurally normal. The cord itself is usually okay.
Contrast that with the much more severe myelomeningocele.
Yes. A myelomeningocele, or open spina bifida, also involves a cystic sac of meninges protruding through the defect. But crucially, the neural tissue within that sac part of the spinal cord, or nerve roots, is abnormal. It's malformed, dysplastic. This inevitably leads to significant neurological deficits below the level of the lesion paralysis, sensory loss, bowel, and bladder problems. That difference, normal versus abnormal neural tissue in the sac, is absolutely fundamental for prognosis and management.
A critical difference. And there are other related malformations surgeons need to be aware of, right? Like tethered cord.
Absolutely. Tethered cord syndrome is where the conus medullaris is abnormally low, stuck down by a thickened filum terminale, a lipoma, or scar tissue. As the child grows, this tethering stretches the cord, causing progressive neurological symptoms, pain, leg weakness, bladder issues.
Okay, and the cord duplications. Diastematomyelia and diplomyelia.
Right. These are rare but important. Diastematomyelia is when the spinal cord is split longitudinally into two separate hemichords. Critically, each hemichord usually has its own dural sheath, and they're often separated by a bony or fibrous spur. Diplomyelia is even rarer again, two hemichords, but they are contained within a single dural sheath. Knowing whether it's one sheath or two is vital if surgery is contemplated to, say, remove a dividing spur.
That makes perfect sense for surgical planning.
Okay.
That gives us a really solid foundation of the development and the potential congenital issues. Now, let's zoom into the adult cord's internal architecture. Looking at a cross-section, what are the major external grooves or fissures we use as landmarks?
Externally, the cord is marked by a deep anterior or ventral median fissure. You can actually see the pia mater lining it. Posteriorly, there's a shallower posterior or dorsal median sulcus, which continues inwards as a glial septum. These two midline grooves are connected internally by the commissural fibers crossing around the tiny central canal. Surgically important are the posterior median sulcus and the paired posterolateral sulci. The posterolateral sulcus is where the dorsal nerve roots actually enter the cord substance. These sulci, particularly the posterior median one, are often considered less vascular planes, potential corridors for surgical entry.
Got it. Now, looking at that classic H shape of the gray matter inside, surrounded by white matter, the relative amounts change dramatically along the cord's length, don't they?
They absolutely do, and it reflects function directly. The amount of gray matter, which is where the neuron cell bodies live, is largest where you need the most neurons. That means the cervical enlargement, roughly C3 to T2, which innervates the arms and hands.
Right, the brachial plexus origin.
Exactly. And the lumbar enlargement, L1 to S3, which innervates the legs and feet via the lumbosacral plexus. These areas have much more gray matter compared to, say, the thoracic cord, which only needs to control the trunk muscles.
Makes sense. More machinery needed for the limbs. Conversely, the white matter, the tracts, is thickest up high in the cervical region and gets progressively thinner as you go down. Why that pattern?
Think about the traffic flow. The white matter contains all the ascending sensory pathways carrying information up to the brain, and all the descending motor pathways carrying commands from the brain.
Right.
As descending tracts, like the main corticospinal tract, travel down the cord, they're constantly sending off fibers to synapse at each level, so they shed volume as they descend.
Right.
Meanwhile, ascending tracts are continuously collecting sensory information from each level as they go up, so they gain volume as they ascend. Put it together, and the upper cervical cord has the maximum volume of white matter because all ascending fibers have joined and all descending fibers are still present. It decreases steadily towards the covus.
That's a great way to visualize it, shedding descending fibers, accumulating ascending ones. Now let's dive into the gray matter H itself. We talk about dorsal, ventral, and sometimes lateral horns.
Correct. The dorsal horns, posterior horns, are primarily sensory. They receive the incoming primary efferent fibers from the body via the dorsal roots. The ventral horns, anterior horns, are motor. They contain the large cell bodies of the alpha and gamma motor neurons whose axons exit via the ventral roots to innervate muscles.
Okay, sensory in the back, motor in the front. What about the lateral horn?
The intermediate or lateral horn is a smaller bulge situated between the dorsal and ventral horns, but it's only present in the thoracic and upper lumbar segments, specifically T1 to L2. This is the command center for the sympathetic nervous system, housing the cell bodies of the preganglionic sympathetic neurons.
T1 to L2 only. Got it. And there's one more subtle feature right at the tip of the dorsal horn, Lissauer's tract.
Yes, the fasciculus of Lissauer. It's a thin little cap of white matter sitting right on the surface, separating the very tip of the dorsal horn from the edge of the cord. When primary afferent fibers, especially the small ones carrying pain and temperature info, enter the cord, many of them bifurcate and run up or down for one or two segments within Lissauer's tract before they actually synapse in the dorsal horn gray matter. It's like a short-term local relay system right at the entry point.
A little waiting room for sensory signals. Okay, now for true mastery, we need to talk about Rext's laminae. This isn't just dorsal ventrolateral. It's a much finer-grained map of the gray matter based on cell structure and function, right?
Exactly. Rext, back in the 50s, divided the entire gray matter cross-section into 10 distinct layers, or laminae, numbered with Roman numerals I through X, starting dorsally and moving ventrally. This cytoarchitectural map turns out to correlate incredibly well with function.
So where do those primary sensory fibers terminate? Which laminae?
Laminae I through 4 make up the bulk of the dorsal horn. These are the main receiving zones for cutaneous primary efferents. Laminae I, the marginal zone, and lamina V get a lot of input from nociceptors, pain fibers. Lamina II is unique. It's very densely packed with small neurons and corresponds to the classical substantia gelatinosa.
Substantia gelatinosa, right. Key for pain modulation.
Absolutely. It's a major site for processing and gating pain signals. Laminae III and 4 receive more input from mechanoreceptors, handling touch and pressure. Overall, laminae I2A are where complex reflexes get initiated and where many ascending sensory pathways originate.
Okay. Moving deeper toward the base of the dorsal horn. Laminae V and 6.
Laminae V and 6 are really interesting integration zones. Laminae V receives converging input in nociceptive, visceral, and descending pathways. Laminae 6, especially prominent in the enlargements, gets a lot of proprioceptive input from muscles and joints, and also significant input from descending motor tracts, like the corticospinal tract. They seem heavily involved in integrating sensory feedback with motor control, particularly for regulating movement and posture.
Integration centers. And the lamina VII, the intermediate zone. You mentioned it includes the lateral horn. What else is there?
Lamina VII is huge and functionally diverse. It lies between the dorsal and ventral horns and extends laterally. It contains several absolutely critical nuclear groups. First, in the thoracic upper lumbar cord, T1, L2, you find the posterior thoracic nucleus, also known as Clark's column. This is the origin of the vital dorsal spinocerebellar tract, carrying unconscious proprioception to the cerebellum.
Clark's column, okay.
Also in T1L2, laterally within lamina VII, is the intermediolateral nucleus. As we said, this contains the preganglionic sympathetic neurons. And running much of the cord's length more medially is the intermedial nucleus, which seems involved in processing visceral sensory information and potentially coordinating visceral motor responses. So lamina VII is a major hub for sensory motor integration, proprioception, and autonomic control.
That's incredibly packed with function. Okay, this detailed map of the gray matter sets the stage perfectly for understanding the major highways running through the white matter, the ascending and descending tracts. Let's start with the descending motor systems, and the big one, the corticospinal tract.
The corticospinal tracts, often called the pyramidal tracts, are the primary pathway for voluntary motor control. They originate from a wide area of the cerebral cortex, especially the primary motor cortex. Their most critical function, particularly the lateral tract, is controlling fine, skilled, fractionated movements, things like individual finger movements, manipulating objects, precise articulation for speech.
And the crossing point, the decussation, is really high up, isn't it, for most of the fibers?
Yes, for the main component, the lateral corticospinal tract. About 85–90% of the fibers descending from the cortex cross over to the opposite side at the lower level of the medulla in a structure called the motor decussation or detussation of the pyramids. They then descend in the lateral white matter column of the spinal cord, contralateral to their cortical origin. This is the tract that controls limb muscles, especially distal ones.
Okay, so damage above the decussation causes contralateral weakness. Below causes ipsilateral weakness for this tract. What about the fibers that don't cross there?
The remaining 10–15% form the anterior corticospinal tract. These fibers descend ipsilaterally, staying on the same side, in the anterior white matter column. They primarily influence axial and proximal muscles, trunk, shoulder girdle, postural muscles. Interestingly, these fibers do cross, but they do it much lower down, at the spinal segment level where they are about to terminate on motor neurons, usually via interneurons.
So they cross near their destination. Okay. Beyond the direct corticospinal system, what other descending tracts contribute to motor control? There's the rubrospinal tract.
The rubrospinal tract originates in the red nucleus in the midbrain. In many mammals, it's a major motor pathway, often considered complementary to the corticospinal tract, perhaps involved in controlling movement velocity or automatic limb movements. In humans, it's traditionally described as less prominent, maybe even rudimentary.
Right, you often hear it's poorly defined.
Exactly. It descends in the lateral funiculus, near the lateral corticospinal tract. However, some evidence suggests it might play a role in recovery after corticospinal tract injury. It's probably more significant than we sometimes give it credit for, perhaps a latent system.
Interesting. What about the tracts from the brainstem, reticular formation, and vestibular nuclei? They're more about posture and maybe gross movements.
Precisely. The reticulospinal tracts arise from the pontine and medullary reticular formation. They descend medially, pontine, and laterally, medullary. These tracts are incredibly complex, involved in integrating sensory input to modulate motor output, influencing muscle tone, posture, gait, and even things like cardiovascular control. They play a huge role in automatic movements and postural adjustments.
Okay. And the vestibulospinal tracts? All about balance.
Directly related to the vestibular system, yes. The vestibulospinal tracts are crucial for maintaining balance and upright posture in response to head movements and gravity. The lateral vestibulospinal tract descends ipsilaterally the entire length of the cord. It exerts a strong excitatory influence, particularly on extensor muscles, the anti-gravity muscles of the spine and lower limbs, keeps us upright.
Important point about its organization.
Yes, it's somatotopically organized. Fibers going to the lower body originate from a specific part of the lateral vestibular nucleus. The medial vestibulospinal tract is different. It travels within a bundle called the medial longitudinal fasciculus, MLF, mainly influences neck and upper back muscles to coordinate head and eye movements, and critically, it only descends to the mid-thoracic level.
So its influence stops partway down the trunk. That's a useful clinical point. Okay, that covers the major descending motor pathways. Let's switch gears to the sensory superhighways, the ascending tracts. You mentioned earlier that the level of decussation is a key diagnostic feature. Let's revisit that with the main sensory systems.
This is absolutely fundamental for clinical localization. Let's start with the dorsal column medial lemniscus DCML system. This pathway carries information about fine discriminative touch, like recognizing objects by feel, conscious proprioception, knowing where your limbs are without looking, and vibration sense.
Okay.
Primary afferent fibers carrying this information enter the dorsal root, and instead of synapsing right away in the gray matter, they turn upwards and ascend ipsilaterally on the same side within the dorsal white matter columns. Fibers from the lower body travel medially in the fasciculus gracilis. Fibers from the upper body travel laterally in the fasciculus cuneatus.
So they travel all the way up the cord on the same side they entered.
All the way up to the medulla. There, they finally synapse in the dorsal column nuclei, nucleus gracilis and nucleus cuneatus. It's the second-order neurons originating from these nuclei whose axons then decussate, crossing the midline as internal arcuate fibers, forming the medial lemniscus, which ascends through the brainstem to the thalamus, VPL nucleus, and then on to the primary somatosensory cortex.
So the key takeaway, DCML information crosses high up in the medulla, A spinal cord lesion affects fine touch and proprioception on the same side below the lesion.
Exactly. Now, contrast that sharply with the pathways for pain and temperature. That's the spinothalamic tract, part of the anterolateral system. It also carries crude touch and pressure.
Okay, how does it work?
Primary afferent fibers for pain and temperature enter via the dorsal root, might ascend or descend a segment or two in Lissauer's tract, and then they synapse almost immediately in the dorsal horn gray matter, primarily laminae first 2 and V.
Right, synapse straight away.
And here's the crucial difference. The axons of these second-order neurons decussate immediately, crossing the midline within the spinal cord itself, usually within 1 or 2 segments of their origin, through the anterior white commissure. They then ascend on the contralateral side, the opposite side, as the spinothalamic tract, heading up towards the VPL thalamus and then the cortex.
So the key takeaway here, spinothalamic information crosses low down, almost immediately within the spinal cord. A spinal cord lesion affects pain and temperature sensation on the opposite side of the body below the lesion.
Precisely. This dissociation, ipsilateral loss of fine touch proprioception, contralateral loss of pain temperature, is the absolute hallmark of a unilateral spinal cord lesion, the Brown-Séquard syndrome we'll touch on later.
That crossing difference is so clinically powerful. What about the tracts going to the cerebellum, the spinocerebellar pathways?
The spinocerebellar tracts are vital for coordinating movement. They carry unconscious proprioceptive information, muscle stretch, joint position, and cutaneous information from the limbs and trunk to the cerebellum, allowing it to smooth out and coordinate motor commands. There are several, but the 2 main ones are the dorsal and ventral.
Okay.
The dorsal spinocerebellar tract, DSCT, originates from Clark's column, laminae 7th, in the T1-L2 segments. It ascends ipsilaterally in the lateral funiculus and enters the cerebellum via the inferior cerebellar peduncle. It primarily conveys information from the trunk and lower limbs relayed up to Clark's column.
Ipsilateral, like the dorsal columns.
Yes. The ventral spinocerebellar tract, VSCT, is a bit more complex. It originates from neurons in the lumbosacral cord gray matter, mainly laminae V7. It carries information predominantly from the lower limbs. Most of its fibers decussate in the spinal cord, ascend contralaterally, loop up through the midbrain, and enter the cerebellum via the superior cerebellar peduncle. Then, confusingly, many fibers cross again within the cerebellum. Functionally, it relays information about the state of spinal cord interneurons and descending commands.
Wow, a double crosser. Okay. We've covered the big ascending and descending highways. But there's also intrinsic wiring within the cord itself, right? Connecting different segments, the propriospinal pathways.
Absolutely essential. The fasciculus proprius, or propriospinal pathways, consist of axons that originate and terminate entirely within the spinal cord. These tracts form a layer of white matter immediately surrounding the gray matter, especially originating from laminae V8. They include short fibers connecting adjacent segments and long fibers connecting distant segments, like cervical to lumbar.
What's their main job?
They are crucial for intersegmental reflexes, coordinating complex movements like walking, and importantly, they mediate many of the automatic functions that can persist even after a complete spinal cord injury above that level. Things like stepping reflexes, some autonomic adjustments, pseudomotor sweating, vasomotor tone, and basic bowel bladder reflexes. They're the cord's internal communication network.
The local network. And what about the brain's direct line to the autonomic system? How does the hypothalamus talk to the sympathetic neurons in that lateral horn?
Those are the hypothalamospinal fibers. These are descending autonomic control pathways. They're quite diffuse and hard to trace definitively in humans, but we know they exist because damage to them, say from a high spinal cord lesion or brainstem stroke, causes specific autonomic deficits. The classic example is Horner's syndrome drooping eyelid phallosis, constricted pupil meiosis, decreased sweating anhidrosis, which results from interruption of the sympathetic supply to the head and face. These fibers are thought to descend mostly ipsilaterally, primarily in the dorsolateral part of the lateral funiculus, eventually synapsing directly or indirectly on those preganglionic sympathetic neurons in the intermediolateral nucleus, T1-L2, and also on parasympathetic neurons in the sacral cord, S2-S4.
Okay, that covers the tracks. Let's pull back now and look at the cord's protective layers, its anchors, and perhaps most critically, its blood supply, which you called precarious earlier. Let's start with the meninges.
Right, the protective coverings. From outwards in, you have the dura mater. This is the tough, fibrous outer layer. It forms the sulcal sac, which encloses the cord and the cauda equina, extending all the way down to the S2 vertebral level.
S2, okay.
Deep to the dura is the arachnoid mater, a much thinner web-like membrane. And adhering directly, intimately, to the surface of the spinal cord itself is the pia mater, a very delicate layer.
And the important spaces.
Between the arachnoid and the pia is the subarachnoid space. This is filled with cerebrospinal fluid, CSF, providing a crucial fluid cushion for the cord. This is the space accessed during a lumbar puncture. Outside the dura, between the dura and the bony vertebral canal, is the epidural space.
That epidural space is clinically huge, isn't it? For anesthesia, but also for other reasons.
Absolutely. The epidural space isn't empty. It's filled with a loose mix of adipose tissue, fat, connective tissue, small arteries, lymphatics, and, importantly, a rich network of thin-walled veins, the epidural venous plexus. It's confined above by the dura attaching to the foramen magnum and below by ligaments around the sacrum. Its contents make it a prime target for epidural anesthesia and steroid injections, but also a common site for metastatic tumor spread and abscess formation.
Okay, so the cord is floating in CSF within the pseudosal sac inside the bony canal.
Yeah.
How is it actually held in place, prevented from just sloshing around?
It has two main anchoring systems. Caudally, we already mentioned the phylum terminale. The pile part, the internum, runs down from the caudamus tip inside the dural sac to S2. Then it pierces the dura, picks up a dural covering, externum, and continues down to attach firmly to the periosteum of the coccyx, the tailbone. That's the main downward anchor.
Got it. And side to side?
Lateral stability comes from the ligamentum denticulatum, or dentate ligament. These are paired, shelf-like sheets of thickened pia mater running along each side of the cord, midway between the dorsal and ventral roots. They extend outwards and form about 21 tooth-like projections, the denticulations, that pierce the arachnoid mater and attach firmly to the inner surface of the dura mater. They effectively suspend the cord within the dural sac.
Like guy ropes. Okay, now the really critical part. The blood supply. The vascular architecture. You said it relies on 3 main longitudinal arteries.
Yes, but they are often surprisingly small and insufficient on their own. There's a single anterior spinal artery, ASA, running down the anterior median fissure, and paired posterior spinal arteries, PSAs, running near the posterolateral sulci where the dorsal roots enter.
What areas do they supply?
This is critically important. The single ASA supplies the anterior 2/3 of the spinal cord cross-section. That includes the anterior and lateral white matter columns, so the corticospinal tracts, the spinothalamic tracts, and the anterior and intermediate gray matter, including the motor neurons in the ventral horn. Basically, most of the motor and paint temperature pathways.
Wow, one artery for all of that.
Exactly. The paired PSAs supply the posterior 1/3, the dorsal columns, fine touch proprioception, and the dorsal horns, sensory processing.
But you said these aren't enough on their own, especially over the cord's full length.
Correct. They need reinforcement. This comes from segmental arteries entering along the nerve roots. Most segmental arteries only supply the nerve root itself, but a few crucial ones, called radiculomedullary arteries, are large enough to also feed into those longitudinal spinal arteries, significantly boosting their flow.
How many of these booster arteries are there?
Usually only about 6 to 8 important ones along the entire length of the cord. They are variable, but common locations include C3, C6, C8 in the cervical region, maybe one around T4, T5, and then critically, one large one usually between T9 and L2.
The famous one.
The arteria radicularis magna, the great anterior radiculomedullary artery, almost always arising between T9 and L2, most commonly on the left side. This is universally known as the artery of Adamkiewicz.
And its significance cannot be overstated.
It is the dominant blood supply for the lower 2/3 of the spinal cord, including the entire lumbar enlargement and the conus medullaris. Loss of this single artery, perhaps during aortic surgery or trauma, can cause catastrophic infarction of the cord from about T8 downwards, devastating paralysis and sensory loss.
It's incredible that so much relies on one vessel. And this leads to the concept of the watershed zone.
Precisely. Because the Adamkiewicz artery provides the major supply from below and the upper radicular arteries supply from above, there's a region in the mid-thoracic cord, roughly T4 to T8, that sits precariously between these two main sources. This area receives the least robust blood supply. It's a watershed zone, making it extremely vulnerable to ischemia if systemic blood pressure drops significantly, like during major surgery, shock, or cardiac arrest. This anatomical setup is arguably the spinal cord's greatest vascular vulnerability.
The ultimate Achilles heel. Is there any connection between the anterior and posterior systems at the very bottom?
Yes. At the tip of the conus medullaris, the ASA and the two PSAs usually form anastomotic loops, sometimes called the arterial arcade of Lazorthes. It provides some terminal collateral circulation, but it's generally not considered robust enough to compensate for major vessel occlusion higher up.
Okay, let's quickly cover venous drainage. You mentioned this has major implications for the spread of cancer and infection.
It does. The venous drainage is somewhat parallel to the arterial supply. Small veins drain the cord into a pilovenous plexus on the surface. This plexus then drains into larger longitudinal spinal veins, anterior and posterior. These, in turn, drain outwards into that rich epidural venous plexus we talked about earlier, and also into veins accompanying the nerve roots, which connect to the major systemic veins outside the vertebral column, like the azygos system.
And the crucial feature of these epidural veins.
They form an extensive network, often called Batson's plexus, and critically, these veins are largely valveless. This means blood can flow in either direction depending on pressure gradients. So if pressure increases in the abdomen or pelvis, like during coughing, straining, or due to a tumor mass, blood containing tumor cells or bacteria can be forced retrograde, backwards, up through Batson's plexus directly into the epidural space and the vertebral bodies.
So it bypasses the usual filters like the lungs or liver.
Exactly. This is widely accepted as the primary route for metastatic spread of cancers, particularly from the prostate, breast, lung, and kidney directly to the spine. It also explains how pelvic infections can sometimes lead to spinal epidural abscesses, a hugely important clinical concept rooted in this valveless venous anatomy.
Definitely. Okay, last piece of this foundational anatomy. The spinal nerves themselves, 31 pairs. What's the basic structure?
Each spinal nerve is formed by the union of two roots within the vertebral canal near the intervertebral foramen. The dorsal root is purely sensory. Its nerve cell bodies are located outside the cord in the dorsal root ganglion, DRG, which sits typically in the intervertebral foramen. The ventral root is purely motor, efferent. Its nerve cell bodies are located within the ventral horn of the spinal gray matter.
Sensory dorsal root with ganglion, motor ventral root without. They join.
They join just at or within the foramen to form the mixed spinal nerve. This nerve is very short because almost immediately after exiting the foramen, it splits into two main branches, or rami. The larger ventral ramus supplies the limbs and the front and sides of the trunk. The ventral rami are what form the major nerve plexuses, brachial, lumbar, sacral. The smaller dorsal ramus turns posteriorly to supply the deep back muscles, erector spinae, and the skin overlying them.
Okay, ventral ramus for limbs and front, dorsal ramus for the back. And we use dermatomes and myotomes to map these.
Right. A dermatome is the specific area of skin innervated by the sensory fibers from a single spinal nerve root. Knowing the dermatome map helps localize lesions. However, there's significant overlap between adjacent dermatomes, so loss of a single root might cause reduced sensation, hypoesthesia, rather than complete loss, anesthesia, except maybe in the trunk, T2L1, where overlap is less. A myotome is the group of muscles innervated by the motor fibers from a single spinal nerve root. Testing specific muscle actions helps pinpoint motor root involvement.
And surgeons also need to be aware of anatomical variations in the roots.
Oh, absolutely, especially in the lumbar spine, where roots are crowded in the cauda equina. Nieder and McNabb described common variations crucial for surgeons performing disectomies or decompressions. Things like type 1, two roots exiting together in a common dural sheath. Type 2, two roots leaving through the same foramen. Type 3, roots connected by an anastomosis, a joining branch. Encountering these unexpectedly can lead to nerve injury if you're not vigilant.
Essential knowledge for safe surgery there. Okay, we have built an incredibly detailed anatomical picture. Now let's pivot to the clinical application. When this architecture is compromised, how do we classify the resulting neurological syndromes? Myelopathy versus radiculopathy.
This distinction is fundamental. Myelopathy refers to any pathological condition affecting the spinal cord substance itself, usually compression, ischemia, inflammation, tumor. The key is that the symptoms manifest below the level of the lesion, and because the descending motor pathways, like corticospinal, are interrupted above the final motor neuron, you typically see upper motor neuron UMN signs.
UMN signs like?
Spasticity, increased muscle tone, hyperreflexia, exaggerated reflexes, clonus, rhythmic muscle contractions, and pathological reflexes like Babinski's sign. Weakness is also present.
Okay, myelopathy is cord damage, UMN signs below the lesion. What's radiculopathy?
Radiculopathy is pathology affecting the spinal nerve root, usually as it exits the spinal canal, Think disc herniation, bony spurs, stenosis. The symptoms are confined specifically to the distribution of that single nerve root. And because the damage is to the nerve root itself or the primary motor sensory neuron pathway at or below the final synapse, you see lower motor neuron LMN signs.
LMN signs like?
Hyperreflexia or areflexia, reduced or absent reflexes at that specific level, muscle weakness in the myotome, muscle wasting or atrophy over time, and sometimes fasciculations, muscle twitches. Pain, numbness, or tingling in the dermatome are also classic features.
So radiculopathy is root damage, LMN signs strictly at that level, and they can occur together.
Very commonly. That's myeloradiculopathy. A perfect example is a large cervical disc herniation at C5-C6. It can compress the C6 nerve root, causing C6 radiculopathy. LMN signs like weak biceps, diminished biceps reflex, pain, numbness, and thumb and index finger. But if it's large enough to also compress the spinal cord itself, it will also cause myelopathy below the C6 level, UMN signs like leg spasticity, hyperreflexia in the legs, Babinski's sign.
That makes sense. So when you're taking a history from someone with suspected spinal cord issues, beyond the obvious motor and sensory questions, what absolutely must be asked?
You absolutely must inquire specifically about bladder, bowel, and sexual function. These are controlled by pathways within the cord, autonomic fibers, laminas seventh, propriospinal tracts, and are often affected early in myelopathy, sometimes before limb symptoms become severe.
What kind of dysfunction are we looking for?
Spinal cord damage often leads to what's called an upper motor neuron bladder, or spastic bladder. Patients might report urinary urgency, frequency, incontinence because the bladder contracts reflexively without proper coordination with the sphincter, detrusor sphincter dyssynergia, leading to incomplete emptying and high pressures. Bowel function can be similarly affected, often leading to severe constipation due to increased colonic tone and poor coordination. Sexual dysfunction is also common. Ignoring these areas means missing crucial evidence of myelopathy.
Vital questions. And clarifying the type of pain is also key, right? Axial versus radicular.
Yes. Axial pain is localized pain in the neck or back itself, often described as deep aching. It usually arises from irritation of the dura, ligaments, facet joints, or muscle spasm around the site of pathology. Radicular pain is different. It's typically sharp, shooting, lancinating pain that radiates along the specific dermatome of the compressed nerve root. Think sciatica radiating down the leg for an L5 or S1 radiculopathy. Distinguishing these helps pinpoint the pain generator.
Okay, let's take that classic spinal cord syndrome. You mentioned Brown-Séquard syndrome as a perfect clinical illustration of the anatomy we discussed. How does it present?
Brown-Séquard syndrome results from damage to one entire half of the spinal cord, a hemisection. It beautifully demonstrates those different crossing points of the major tracts, so below the level of the lesion. On the same side, ipsilateral as the damage, the patient loses fine touch, vibration, and proprioception because the dorsal column pathway ascends ipsilaterally and is cut. They also have UMN-type paralysis because the lateral corticospinal tract, which mostly crossed higher up, is cut on that side.
Okay, ipsilateral touch proprioception loss and UMN weakness.
Yeah.
What about the other side?
On the opposite side, contralateral, below the lesion, the patient loses pain and temperature sensation. Why? Because the spinothalamic tract fibers crossed over almost immediately after entering the cord and ascended on the side opposite the entry point. So the hemisection cuts the already crossed fibers coming from the other side of the body.
That dissociation is striking. Ipsilateral motor and fine touch loss, contralateral pain, and temperature loss. Perfect anatomical correlation.
Exactly. At the level of the lesion itself, you might also see a band of LMN signs and complete sensory loss due to damage to the gray matter and exiting roots right there. It's the classic textbook example of applying spinal tract anatomy.
Definitely. Okay, moving to the physical examination. What are the key objective UMN signs you look for that really scream myelopathy?
We're looking for evidence of disinhibition, the release of spinal reflexes from cortical control. First, hypertonia, increased muscle tone. It's crucial to feel the quality. Is it spastic tone, which is velocity dependent, gets worse with faster movement? I might have a clasp knife feel. Or is it rigid tone, like lead pipe or cogwheel rigidity seen in Parkinson's, which is constant throughout the range of motion? Spasticity points to UMN cord.
Okay, differentiate spasticity, then reflexes.
Hyperreflexia, exaggerated deep tendon reflexes, DTRs. Sometimes they're so brisk you can elicit them just by tapping your finger on the tendon, or you see the reflex spread to adjacent muscles.
And specific named pathological reflexes.
Yes, there are several key ones. Hoffman's sign. You flick the patient's middle fingernail downwards. A positive sign is involuntary flexion of their thumb. An index finger indicates cervical cord compression, UMN lesion,
Okay.
crossed adductor reflex. Tapping the patellar tendon on one knee elicits the normal knee jerk on that side, but also causes the opposite thigh to adduct, move inwards. Indicates bilateral UMN hyperexcitability.
Right.
Ankle clonus. You sharply dorsiflex the patient's foot and hold it. If you get sustained 5 beats, rhythmic, involuntary beating of the foot up and down, that's clonus, a strong sign of UMN lesion.
More than 5 beats is abnormal.
Correct. And finally, the most famous one, Babinski's sign, or extensor plantar response. You stroke the sole of the foot firmly from heel to little toe, then across the ball. The normal response is toe flexion. An abnormal UMN response is the great toe extending upwards, dorsiflexing, often with fanning of the other toes. That's a definitive sign of corticospinal tract dysfunction.
Hoffman's, cross adductor, clonus, Babinski, got him. And just to lock it down, let's quickly recap the root levels for the main DTRs we test routinely. These help localize LMN problems radiculopathy.
Absolutely. The biceps jerk tests the C5 and C6 roots via the musculocutaneous nerve. The brachioradialis jerk, tapping the forearm near the wrist, is mainly C6, radial nerve. The triceps jerk is C7 and C8, radial nerve.
Upper limb, biceps C56, brachioradialis C6, triceps C78, lower limb.
The patellar or knee jerk tests L3 and L4 roots via the femoral nerve, and the Achilles or ankle jerk tests S1 and S2 roots via the tibial nerve. Absent or diminished reflexes point towards pathology at that specific root level.
Perfect. L34 for knee, S12 for ankle. Okay, one final clinical classification before we talk surgery. Spinal cord tumors. How are they grouped anatomically? This really dictates the surgical approach.
Right. We classify spinal tumors based on their relationship to the dura mater and the spinal cord itself. It falls into 3 main compartments. The most common group, about 55%, are extradural. These tumors are outside the dura mater in the epidural space. And the vast majority of these are metastatic tumors that have spread from elsewhere, typically lung, breast, prostate, kidney lymphoma, often via Batson's plexus.
Okay, extradural, outside dura, mostly mets. Next.
Second most common, around 40%, are intradural extramedullary. These are inside the dura, in the subarachnoid space, but outside the substance of the spinal cord itself. They arise from the meninges or the nerve roots. The most common types here are meningiomas from the arachnoid cap cells and nerve sheath tumors like schwannomas and neurofibromas from Schwann cells of the nerve roots.
Intradural extramedullary is inside dura, outside cord, like meningiomas, schwannomas, and the rarest.
The rarest group, only about 5%, but often the most surgically challenging, are intradural intramedullary. These tumors arise within the actual parenchyma, the substance, of the spinal cord itself. The 2 main types here are ependymomas, arising from the ependymal cells lining the central canal, about 60% of intramedullary tumors, and astrocytomas, arising from astrocytes within the cord, about 30%.
Intramedullary, inside the cord substance. Ependymomas and astrocytomas mainly. Okay, it's these intramedullary tumors that really demand the most delicate surgical techniques, including the myelotomy. Let's transition now into the core surgical procedures. How do you approach an intramedullary tumor?
The whole philosophy for intramedullary tumor surgery is maximal safe resection with minimal neurological injury. The standard approach is posterior, midline incision, removal of the laminectomy over the involved segments. Then the dura is opened carefully, usually longitudinally right in the midline, which tends to be less vascular.
Okay, dura open. Now the critical step, the myelotomy. Where do you make that incision into the cord itself?
The preferred location for the myelotomy is almost always along the posterior or dorsal median sulcus.
Why there specifically?
Couple of reasons. Anatomically, it's often perceived as a relatively avascular plane between the territories supplied by the posterior spinal arteries. More importantly, the tumor growing inside the cord often naturally expands and thins out this midline region, sometimes even creating a visible bulge or discoloration right at the dorsal median sulcus. It essentially presents a natural corridor for entry.
The tumor helps create the path.
In many cases, yes. If the tumor is clearly located far laterally, the surgeon might occasionally consider entering through the posterolateral sulcus, the dorsal root entry zone, but the midline is generally favored. The incision itself is done microscopically, often using fine cautery or a laser, just enough to expose the tumor capsule. Then the resection proceeds using microsurgical dissection techniques, sometimes with an ultrasonic aspirator to debulk the tumor internally, always trying to develop a plane between the tumor and the compressed functional spinal cord tissue. And all of this, absolutely critically, under continuous neurophysiological monitoring.
We'll come back to monitoring. Another highly specialized procedure is DREZ lesioning. What's the indication and goal here? It's for pain, right?
Yes, dorsal root entry zone, DREZ lesioning, is reserved for severe, debilitating, medically refractory neuropathic pain, particularly the kind that occurs after nerve root avulsion injuries, like a brachial plexus injury where the roots are torn from the cord, or sometimes after spinal cord injury itself. The underlying idea is that chronic deferentation leads to hyperactivity and pathological firing in the dorsal horn neurons.
So the goal is to destroy those hyperactive zones.
Precisely. The goal is to selectively destroy the nociceptive pain-transmitting fibers as they enter in the lateral part of the dorsal rootlet bundle, destroy the excitatory medial part of Lissauer's tract where these fibers travel briefly, and crucially, destroy the hyperactive neurons themselves, primarily in the superficial dorsal horn laminae like lamina I substantia gelatinosa and maybe lamina V.
How is the lesion made?
It's typically done using radiofrequency coagulation. A specialized electrode is inserted precisely into the DREZ, usually about 2-3 millimeter deep, targeting that posterolateral sulcus region. Lesions are made sequentially along the affected segments, plus usually one segment above and below the main pain zone to ensure adequate coverage. There are different techniques, like the Neshold coagulation technique or the Sindhu microsurgical rhizotomy, which involves cutting specific fibers. It's highly targeted destruction.
Okay, now shifting from pain to motor control spasticity. Selective dorsal rhizotomy, SDR, is a key procedure, especially in cerebral palsy.
Yes, selective dorsal rhizotomy, SDR, is primarily used to treat severe spasticity, most commonly in children with spastic diplegic cerebral palsy, where the spasticity interferes significantly with walking and function. The rationale is that spasticity is caused, in part, by an imbalance of sensory input to the spinal cord, with excessive excitatory feedback coming through the dorsal roots.
So the idea is to reduce that excessive sensory input.
Exactly, but selectively. You don't want to cut all sensory input, as that would cause numbness and potentially worsen function. The procedure typically involves a laminectomy at the level of the conus medullaris, exposing the L2 to S2 nerve roots. Each dorsal root is then carefully isolated and teased apart under the microscope into its individual rootlets or fascicles, usually 3 to 5 per root.
Okay, separate the rootlets. Then what?
Then comes the selective part. Each individual rootlet is electrically stimulated, usually with a train of pulses, tetanic stimulation, while an electromyogram, EMG, monitors the muscle responses in the legs. The surgeon identifies which rootlets produce abnormally strong, sustained, or spreading muscle contractions. These are considered the ones carrying the most pathological spasticity-inducing signals.
Find the bad actors.
Find the bad actors. Then, the surgeon selectively divides a proportion of these hyperactive rootlets, typically aiming to cut about 60–65% of the dorsal root input across the L2S2 levels, while carefully preserving the rootlets that give normal or minimal responses. The goal is to reduce the spasticity significantly while preserving adequate muscle strength and sensation.
A very nuanced procedure. Historically, for severe cancer pain, another procedure was cordotomy.
Yes, cordotomy, specifically anterolateral cordotomy, was a mainstay for intractable unilateral cancer pain, particularly before modern palliative care and opioid management became so advanced. The mechanism is straightforward. It aims to ablate or destroy the spinothalamic tract on one side of the spinal cord.
The ascending pain pathway.
Exactly. Since the spinothalamic tract carries pain and temperature sensation from the opposite side of the body, lesioning this tract produces analgesia on the contralateral side below the lesion. The standard technique evolved into a percutaneous radiofrequency ablation, often performed under CT guidance, targeting the spinothalamic tract high in the cervical cord, usually at the C1-C2 level.
C1-C2, okay. Still used much.
Its use has declined significantly with better medical pain management, but it can still be very effective for specific cases of severe unilateral somatic cancer pain refractory to other treatments. Historically, it provided dramatic relief.
Okay. And one more intervention for syringomyelia, those fluid-filled cavities in the cord. Sometimes shunting is needed.
Yes, syringomyelia is a condition where a cyst or syrinx forms within the spinal cord. It's often associated with other conditions like Chiari malformations or previous spinal cord injury or tumors. If the syrinx expands and causes progressive neurological deficits, pain, weakness, sensory changes, and if treating the underlying cause isn't possible or doesn't halt progression, then draining the syrinx with a shunt might be considered.
How does the shunt work?
A small tube, the shunt catheter, is inserted directly into the syrinx cavity. This usually requires a laminectomy and durotomy, similar to tumor surgery, and then, critically, another midline myelotomy to open the cord and access the cavity. The catheter is then tunneled under the skin and connected to drain the excess fluid into another body cavity, most commonly the peritoneal cavity, syringoperitoneal shunt, or sometimes the pleural cavity, syringopleural shunt.
Sounds risky, involving another myelotomy.
It is. Complication rates are relatively high. There's the risk of neurological worsening from the myelotomy itself. Shunts can also malfunction. They can get blocked under drainage, or sometimes drain too much fluid, over drainage, leading to cord collapse. Infection is also a significant risk. It's generally reserved for cases with clear progressive deficits where other options have failed.
A procedure of last resort. Often. Okay, that covers the core procedures. Let's synthesize this. What are the overarching surgical pearls or tips, and the key anatomical hazards surgeons absolutely must respect in this field? Accessing intramedullary lesions, for instance.
The guiding principle is finding safe corridors. As we mentioned, intramedullary tumors often help by expanding and thinning the dorsal median sulcus, making it a relatively avascular plane of entry. Surgeons learn to recognize subtle cues on the cord surface that indicate the safest place to make the myelotomy. Once inside, maintaining exposure gently is key. Techniques like using pia hitch sutures, tiny sutures placed in the pia mater and tacked to the dural edges, can help retract the myelotomy edges gently without causing excessive trauma.
Exploiting the pathology itself, and we keep coming back to it, but minimizing neurological deficit relies heavily on monitoring.
Absolutely non-negotiable. Continuous intraoperative neurophysiological monitoring, IONM, is the standard of care for almost all intrinsic spinal cord surgery. This involves constantly monitoring both motor-evoked potentials, MEPs, which are generated by stimulating the motor cortex, and recording responses from muscles to test the integrity of the descending motor tracts, like corticospinal.
Okay, MEPs for motor.
And somatosensory evoked potentials, SSEPs, generated by stimulating peripheral nerves like tibial or median, and recording the signals as they travel up the spinal cord, primarily dorsal columns, to the sensory cortex. SSEPs test the ascending sensory pathways.
SSEPs for sensory. What's the protocol if they change?
The protocol is strict. If there is a significant sustained deterioration in either MEPs or SSEPs, usually defined as 50% amplitude drop or significant latency increase, the surgical maneuver causing it must be stopped immediately. You pause, you communicate with the anesthesia team, check blood pressure, temperature, etc. You wait to see if the potentials recover. If they do, you can proceed, but extremely cautiously. If they don't recover, you may need to seriously reconsider the extent of resection or change the surgical plan. It's the cord's real-time functional status report.
The ultimate safety net. The other major source of problems after these surgeries is CSF leak, right?
Yes, cerebrospinal fluid leak is a significant cause of morbidity. After opening the dura, especially after a long incision or if the dura is fragile, getting a watertight closure is crucial but can be difficult. A leak can lead to wound breakdown, pseudomeningocele formation, a collection of CSF under the skin, and potentially meningitis if bacteria track inwards.
So how do you minimize that risk?
The gold standard is meticulous primary suture closure of the dura itself whenever possible, using fine sutures. Sometimes, if the dura is too damaged or thin, surgeons will use a dural substitute graft like processed pericardium or synthetic materials sewn in place, often augmented with fibrin glue sealant. Postoperatively, strategies to reduce pressure on the closure might include placing a temporary wound drain, subfacial, not subdural, sometimes using a temporary intradural lumbar drain to divert CSF flow for a few days, and enforcing a period of strict bed rest, often flat or with minimal head elevation, until the dural repair is deemed stable.
Meticulous closure and pressure management. Okay. We've journeyed from the cord's embryonic beginnings through its intricate wiring and vulnerabilities right up to the high-stakes world of surgical intervention. It's an incredible system.
It really is. And the mastery-level insights, the things you absolutely need to carry forward from this deep dive, I think they center on, well, three main areas. First, that fundamental developmental mismatch between cord and spine, leading to the cauda equina and the variable conus that dictates all positional understanding. Second, the exquisite functional segregation within the gray matter as mapped by Rex's laminae. Understanding which laminae handle pain versus proprioception versus motor output is key to interpreting clinical signs and understanding disease processes.
Functional segregation. And third,
and perhaps most critically for survival, the profound importance and inherent vulnerability of the vascular supply. The reliance on that single anterior spinal artery, the make-or-break role of the artery of Adamkiewicz, and the constant threat posed by that mid-thoracic watershed zone. Understanding spinal cord blood flow is life or death.
Developmental mismatch, Rex's functional map, and the precarious vascular supply. Those are definitely core takeaways. You listening now really have those structural and functional coordinates, not just for memorization, but for genuine critical thinking when faced with complex spinal cases. You can connect the dots from a subtle sign back to a specific tract or lamina.
Which leads us, I suppose, to a final provocative thought. When you truly consider the fragility we've discussed, that watershed zone, the reliance on just 6 to 8 tiny radiculomedullary arteries, the potentially catastrophic impact of losing Adamkiewicz, it makes you wonder, doesn't it? How much built-in redundancy or compensatory capacity does the system actually have? How does the body cope with, say, mild chronic reductions in perfusion to that watershed zone? What's the real margin for error we operate with daily, relying on this incredibly high-stakes anatomical design?
A sobering thought indeed. How resilient is this delicate lifeline, really? Something to definitely ponder. Thank you for that incredibly deep dive.
My pleasure. It's a fascinating and vital area.